So really quickly, I just want to go over some of the biggest differences between diabetic ketoacidosis and hyperosmolar hyperglycemic syndrome. There's a nice little chart here, so you can see, it's kind of just broken down, which is great. But I don't know about you, but sometimes when I see these in a textbook, I'm like, it just means nothing. My eyes just go over it. So I have to stop and break down and go, okay, well, why? Why is this and why is that? So let's look at this. With DKA, how did they split this up here? Positive. Okay, so one of these is DKA and the other. So I think this is DKA and this is HHS. I'm sorry, I'm not sure why there isn't like a label, like that's not labeled more clearly. So ketones, let's talk about ketones. In DKA, they are positive. In HHS, they are absent. Why? Because in DKA, we have an absolute insulin deficiency. There's nothing there to stop the body from breaking down fats and producing keto acids, okay? In HHS, your body still is trying to break down the fat because it thinks it's not getting enough glucose, even though it has just tons of glucose in its blood. The cells just aren't using it. So it's going to break down fat, but when it gets there, there's enough insulin in the body to stop it from happening. Insulin works against that lipolysis. And because of that, because there isn't an absolute deficiency, you don't have the breakdown of lipolysis, which means you don't have ketones. No ketones means no acidosis. So you do not necessarily have an acidosis in HHS. You shouldn't. You are going to have that acidosis here in the DKA. Glucose, again, it's going to be above 14-ish in DKA and above 20, 34. The bottom line is it's high. Usually by the time the patient comes in to emerge, their glucose level is much higher in HHS. The theory is that the symptoms of DKA, not just the polyuria, polydipsia, polyphagia, but this acidosis causes pretty severe nausea, vomiting. And that is often what brings the patient in. Plus acidosis, like I've said this before, acidosis, for the most part, every single patient I've ever seen who's been in metabolic acidosis just looks like crap. You can see it. You can see that they come in and you're like, this patient is sick. So they just feel so bad. They come in quite a bit earlier and they get treatment earlier. Another thing is that because DKA only happens in type 1 diabetes, right? Because type 2 diabetes, you're always going to have some insulin. For the most part, you'll have some insulin. So you're not going to have that acidosis. But DKA happens mostly with younger people. Younger people have a much, for the most part, have a higher GFR, meaning they're able to clear more glucose into their urine. So they're actually excreting a lot more of the glucose. So the glucose that's left in their blood isn't necessarily as high as it's going to be in HHS. The reason you're going to have very high osmolality in HHS, why it's called hyperosmolar hyperglycemic syndrome, is because of all that glucose. That glucose in the system that hasn't been diuresed out, you haven't come in to emerge yet because you feel kind of crappy, but you don't feel this bad. And it has changed the osmolarity of the kind of the fluid system in the body. I explained this in the last video, so I'm not going to go over it again. But you end up with this very osmolality, and pulling out lots and lots and lots of fluid. In both DKA and HHS, you're going to have a decrease in you'll originally have a normal or elevated potassium, but keep an eye on it because it is most likely going to drop. It's going to be lost through diuresis. It's obviously, because we have more diuresis in HHS, we probably will have faster, and it's more common to have potassium loss, but you will still have this. There's a lot other things going on with your hydrogen and your acidosis and all of this, so there will be usually a drop in potassium as well. Sodium is going to be relatively normal. There will be issues with sodium, but for your purposes, for this test, and even for NCLEX, I wouldn't worry too much about it. If you have to think it through, you can. You know, in HHS, you have this hyperosmolality. You have decrease in fluids, right? So your sodium will be high, but it's that kind of high sodium that comes with low fluid. Not necessarily you have too much sodium, it's that you need more fluid. I promise at some point I'm going to make an entire video about fluids and electrolytes, so you'll be able to look and understand that a little better. In diabetic ketoacidosis, you're going to have a normal to low sodium, and that's just because you don't have as much of that diuresis. Again, here you've got slightly high osmolality, here you've got insanely high osmolality. Do not memorize these numbers, do not worry about them. And then the only other thing we're looking at is bicarb. And in diabetic ketoacidosis, you know what, this doesn't actually make sense to me. So in my head, your bicarb would be high because it's trying to compensate. I think maybe it's low because it wasn't able to compensate. It depends on where you are in that. But listen, for most of you who are, you know, studying for the test right now, that's not going to be an issue. When you go to study for the NCLEX, make sure you come back and really understand the acid-base balance, and that will help you a lot. But for now, this is enough to be able to answer questions that are going to pop up on your test. So really quickly, the differences in symptoms between Dka and Hhs. If you understand what I just talked about here and what we talked about over here, this is not difficult. You're going to have the big differences here is this nausea and vomiting, because it comes from the acidosis. You don't have the acidosis in HHS, you don't have that nausea and vomiting. What you do have here are these neurological changes. That's your trigger to, in a test, to say, okay, like that's HHS. So the nausea and vomiting from acidosis, DKA. The neurological changes, and it's not, just so you know, it's not that you don't have any neurological changes in DKA, so just be careful of that. But I said this is like really major in HHS. You're going to see it, and it's going to look sometimes, it's going to look a lot like a stroke. So you might have hemiparesis and so on. So hopefully after all of that, you will have no problem determining on a test the difference between DKA and HHS.